Okay, cool. We are live. Dr. Simmons, you want to play our intro song? You should totally play our
Our,
intro song.
our
Let's do
intro
it.
song. Oh, yeah, we're gonna
Let's do our
jam.
intro song.
Oh
Yeah,
yeah. Am I the entertainment?
you are. You're the entertainment. Let's do it. You are now listening to Dr. Ron and Dr. Simmons. That's a great intro song.
That's fun.
Thank you for the awesome 12 string that you have right there. That's a
Yeah.
pretty badass guitar. So yeah, so thanks for coming on. Last week or the week before, I can't remember. The week before, I sent out this thing called the skull brain connection to my email list and had Dr. Felix Liao, an airway dentist, come and actually talk about skull and oral airway features and how that correlate with pediatric brain development. We're going to complete the full circle with you, Dr. Simmons. So, Dr. Jerald Simmons here is a triple board certified neurologist in the field of sleep, epilepsy, and neurology. And he's been really helping us at Texas Center for Lifestyle Medicine try to find root causes of brain and neurological health disorders and really connecting pieces of the puzzle that people don't conventionally think about. So that's what we're going to talk about today. And the topic of discussion is the skull brain connection. And, Dr. Simmons did a TED Talk, which is TEDx Sugarland, which you can find on YouTube. And it's a great talk talking about this character named Johnny progressing through life from pediatric age into adult age. Even the jobs that he chose, the relationship issues that he had, really relating to oral airway and oral health, but people were seeing it as like mental health issues or behavioral issues or brain health issues. So really want to close the gap together on that. And then we're going to touch on what a lot of people want to hear about, which is, well, how is this related to like the COVID brain fog that we hear about also, right? Or the long haulers as well. And so let's get started. So, Dr. Simmons, thank you for playing our intro on guitar.
My pleasure.
That was awesome. I feel like a radio show.
Yeah.
So let's get started. I would love to kind of have you dive into Johnny, what you talked about on TEDx back in the day, and let's discuss who this Johnny person is, and then kind of relate brain and skull and oral airway health and all the stuff into it.
Well, the character of Johnny is what would be considered a common kind of child these days.
Mm-hmm.
Johnny had some issues. He didn't feed very well,
Yeah.
and was sort of irritable as a child. And there was already some early signs that Johnny had some craniofacial aspects that were deficient and made it harder for him to feed, but also affected his breathing. And Johnny had a mild form of obstructive sleep apnea.
But I mean, this is not really picked up in modern day very effectively, right?
No, there's a big deficiency in our healthcare education system that most pediatricians and dentists, pediatric dentists, they're really not taught about some of the features to be looking at the oral airway. I mean, people talk about cavities in kids, and they talk about malocclusion and the teeth not being straight,
Right.
but they're not thinking about the airway. And when you don't breathe normally, then it has such a large cascade of effects that snowball and can have many detrimental effects downstream, but they originate from something right here, the entry point, the airway.
Right. And a lot of this could be related to like later on diagnoses of like attention deficit, right? And behavioral changes as a child, right?
Totally.
And, yeah. And
so, what is ADHD? I mean, really, it's a symptom complex, and there's many pathways to get to there. And what's overlooked so frequently is the sleep component. And, by not getting proper sleep at night, then you are carrying around an excessive propensity to go to sleep, an increased what we call sleep drive. And so in order to stay awake, you have to increase your activation level. because there's whether you're awake or asleep depends on the balance between two competing processes, the sleep drive and the wake drive. But if you're carrying extra degree of sleep drive or sleep propensity, then you have to be more hyper in order to stay awake. So you're constantly physically stimulated. And
So let's relate that to the character of Johnny real quick. So what would like kid Johnny look like, and how is that related to poor quality sleep?
can't sit still in school, acting
Okay.
out, behavioral problems, can't focus, can't concentrate to do homework, and then starts having inappropriate behaviors, getting in trouble in class, and isn't able to perform like other children. And even though he might try, but he just doesn't seem to be able to have the concentration capability. So there are behavioral issues. And then maybe Johnny's mom was actually noticing Johnny's sleeping with his mouth open, drooling on the pillow. He's a mouth breather. Mouth breathing during sleep is a red flag because the pathway of least resistance should be through the nose. And so there are subtle signs that I described in the TED Talk about Johnny that make it clear that there is an issue. And then Johnny's mom brings Johnny to the pediatrician, and all he does is write a prescription for a stimulant. Now, the stimulant is going to pharmacologically mask the problem because instead of having to be physically stimulated, now you're pharmacologically stimulated. So now you can sit still and you're not going to have this propensity to want to be sleepy. So you don't have to be hyperactive.
Well, let's define a stimulant. What are some example of stimulants that
Ritalin, Adderall, Vyvanse.
Vyvanse, okay, yeah.
And those are being prescribed at such an alarming frequency. I mean, right now there's actually a national shortage of some of these medications because you just disrupt the supply chain a little bit, and there's such a high demand for these drugs that there's a problem. But again, most physicians don't understand that they need to look for a sleep problem in these kids. So,
and in fact, a lot of physicians that we talk to, they're almost surprised when we talk about, hey, if you got ADHD in kids or adults, like one of the first things you should do is actually get a sleep study done, right? To figure out,
or at least take a sleep history. And then the question is, well, so then the question is, well, what kind of things do you look for in a sleep history? One would be mouth breathing. One would be just restless sleep throughout the night, or a child that's having difficulty staying asleep, or a child that's hard to wake up in the morning. Or maybe they're kicking in their sleep. And not all sleep problems do relate to breathing issues. A lot of restless leg syndrome can occur in kids. It's very frequent. And some kids will have both conditions. So, and if someone wants to learn how to take a sleep history, I mean, the course, we'll talk a little bit about the course. That's a real big opportunity for people to go to one course and learn so much about sleep because there's such a deficiency in our healthcare education system. Most physicians and dentists, they're not given proper education on sleep. Only 2 to 4 hours are spent over the 4 years of medical education teaching about a process that we spend a third of our life doing.
Yeah, and I'll tell you what, I guess I was Johnny because I was not the best kid in the world, and I was always kind of uppity, right? And I channel that, it's a big deal. And later on in life, I was diagnosed with sleep issues and obstructive sleep apnea, which really created a huge paradigm shift, for me. Let's go back to Johnny for a second, right? So we identified, hey, Johnny, a little restlessness, agitation. Sometimes you have that afternoon giddiness a little bit. Go to a pediatrician, not necessarily end up being diagnosed with sleep disorder, but get diagnosed with ADHD, get prescribed Ritalin, Adderall, Vyvanse, whichever one it is. So how does typically Johnny progress after that if it's not diagnosed as sleep disorder?
So as I described in the TED Talk, initially he does well, but that benefit is not sustained, and then the dosages are increased, the medications are modified, and then Johnny starts having other kinds of issues, and they start diagnosing with bipolar disorder. Getting highs and lows from medicine, and it's really playing a role on his whole limbic system and his emotional stability from these medications. And he's constantly still fighting the underlying pathology, which is the sleep issue. So he is really challenged with a lot of issues, diagnoses, and limitations.
Right.
And he's realizing that he's just going to not be a very successfully, he's not an academic career was not something that he was going to pursue.
it's translates into behavioral patterns, right? And so this, it's the first diagnosis was like psychiatric diagnosis is ADD or ADHD. Second one potentially is, bipolar or mania disorder or anxiety or something like that, right? And so, and of course, we're seeing the manifestations of this in adulthood as well, right? And so, how do adults typically present like this, never being diagnosed with any airway breathing disorders?
Well, there's a whole spectrum of how they can present, I guess. So, um, but a typical scenario with this would be that he uh, may develop certain behaviors where he's busy working all day long, and then in the evening he's going to sit down in front of the TV and have a few beers
Yeah,
and just and eat and gain weight. And this breathing problem, which may have been more subtle initially, starts becoming more severe and becoming more detrimental to his cardiovascular uh,
yeah,
system, and leading to what it becomes a much easier diagnosis to make later on in life of obstructive sleep apnea. But earlier in life, it may have been this more subtle form, which we'll call the upper airway resistance syndrome. It's all on a spectrum of various degrees
right,
of obstructive breathing during sleep. And a lot of times individuals will be grinding and clenching their teeth, which
yeah.
is an attempt to keep the airway open. And then it's going to have its detrimental effects on the temporomandibular joint, destroying the enamel of the teeth. And so people are treating it just for a dental problem, but it's a sign of an airway problem. We've shown that once we treat obstructive sleep apnea with something like CPAP, that the clenching process resolves if you're treating it properly. So,
That's a really important point because a lot of people, and this is how I viewed it. Going through medical training, is that if you have like TMJ jaw issues, we're not really taught to see it as a compensation mechanism, and that's what it really is, right? It's compensating because your brain wants to trigger mechanisms to keep your airway open because your poor brain just wants you to be alive, right? And as it trigger these mechanisms and airway open, you have the masseter muscles that clench down, which in turn anchors the temporomandibular joint, and that can get painful or loose. And then you have your sternocleidomastoids, and then all your fascia like pulls your jaw forward, like this motion right here. And people were waking up with neck pain, or they may be diagnosed like fibromyalgia over a long period of time, right? And so there's all these different like chronic diagnoses with no end that seems to come from sleep-related disorders and airway breathing-related disorders, right? And so, I think that's the message here is we got to be able to get rid of the stigma of this because we know there's a mental health stigma, right, in the Western society. We know there is, but to know that a lot of the mental health disorders can be correlated with something medical or structural, like the airway and the skull, right? That's a big deal for people to understand and take away because there's things that we can do about it, right? And the people suffering, and Susie just commented, oh wow, I never thought that correlated with TMJ. Absolutely. TMJ is actually in our sleep questionnaires that we have to identify sleep disorders, Susie. And so the correlation is that, okay, now we're going beyond that. Well, a lot of people who have TMJs have these diagnosed with headaches, potential headaches or migraines, right? Now we have a component of migraines into it as well. So there's all these different diagnoses that really seem to have no end that kind of correlate back into sleep dysfunction. And sleep dysfunction can potentially correlate back to airway compromise, skull formations, right? And that's a big deal for people to understand. Okay, so let's take Johnny a little further. So now that Johnny's an adult. So Johnny, as a kid, diagnosed with attention deficit disorder, put on some sort of stimulant, never really identifying or treating the sleep disorder. Johnny grew up a little bit, is sort of in this adulthood or maybe diagnosed with other disorders like bipolar and stuff like that, right? Now let's progress Johnny a little further along for a little bit, okay? And so let's make Johnny like 65 years old, right? So
well, or if he lives that long.
if he lives along, right? Because we know that sleep disorders are an independent risk factor for the top 3 causes of death in the United States: strokes, heart attack, and cancer, right? So these are the independent risk factors for the top 3 causes of heart attack. So let's progress to 65 years old. And I think you know where I'm getting at, which is Alzheimer's. So let's kind of progress that to at that time. So what are we seeing later on in life with Johnny?
Well, so in an individual that's going to have this obstructive breathing problem during sleep, they're going to get microvascular compromise. So, it's a part of the aging process is to get a degradation of the capillaries in the brain. And that's sort of normal as you get older, but that process can be accelerated, particularly when you have obstructive breathing at night. Your blood pressure is actually fluctuating. It's going up and down. And there's a whole process that, we don't have time here for me to explain the physiology, but basically your blood pressure is constantly fluctuating.
Yeah.
And with that, whenever it drops, you get this vasoconstriction, and then all of a sudden, boom, there's an increased output from the left side of the heart. Now you're pushing all this extra blood down against the clamped down microvasculature,
right,
and it causes microscopic trauma. But when this happens over and over again, it increases the risk of having what we call lacunar stroke. So you can get multi-infarct dementia is clearly something that can be accelerated by having obstructive sleep apnea. And the statistics that we have are really not that good because the sleep apnea component is so underdiagnosed. Right. And so it's much more prevalent. Now, that's just one form of dementia.
Right.
We also know that during slow wave sleep, we have the glymphatic system. It's like the lymph system of the brain. And that's when you're washing out toxins. And it is most active during slow wave sleep. But if you're fragmenting your sleep because of these repetitive obstructive respiratory events, you're not going to get the slow wave sleep that you normally would have gotten. And that can be impairing the glymphatic flow during slow wave sleep. So you are in the normal scenario, you're going to be washing out most of the toxins during slow wave sleep. So if you don't get proper slow wave sleep, you're not washing out these toxins. So what are some of the toxins we're talking about? Well, amyloid, the breakdown of amyloid, that might be, it's part of the normal process of recycling within neurons, but you're not washing out the breakdown products. And so they're going to be accumulating, and they can actually clog up neurons, and then that can cause further neuronal death. And so you can get a breakdown of neuronal tissue from a sleep problem because of decreasing lymphatic flow. That's a current hypothesis that's being evaluated. There's a lot to point to this probably being one of the pathways that's leading to neuronal degeneration in the brain.
Yeah, and not just that, right? Because whenever you have the lymphatic system that gets impaired because you don't get enough restorative sleep or into deep sleep, you also have the misfolding of amyloid plaques as well. So these amyloid plaques are supposed to protect it as part of our immune system. And when they aggregate, they either fold one way or another. We call them different subunits folding. And so without proper sleep, it folds in a way where it can create even more inflammation to sequester whatever toxins that are there. And, post-mortem studies, are showing that pathologists are cutting to the brain are finding exactly what toxins are there. Most of these brain samples have like P. gingivalis from like periodontal disease and dental illnesses. They have spirochetes, which basically are these atypical organisms that can also hang around the dental areas. They have other organisms like strep that's supposed to hang out in the sinuses. So much of their skull is reflected in these amyloid plaques post-mortem studies when they kind of cut into the plaques as well. And so there definitely needs to be a humongous focus on sleep disorders. And so we have Anne here saying that, hey, once you're treated, what is she saying? Once you are getting treatment for sleep apnea, and you have been grinding and clenching for years, will you stop with it being so ingrained? So I guess it's like, will it improve the grinding?
Yeah. So, other words, is the individual so conditioned that they're going to continue doing it regardless?
Yeah.
So, the only data that I can tell you is based on years of clinical experience that there, and also looking at sleep studies, that we've seen the reduction of, so when we do a sleep study, we actually do a more elaborate study than most sleep labs. We put actually 6 channels on the face on the temporalis, masseter, and submental region on every in-lab sleep study that we're doing. And then we also do the studies with, not all studies, but frequently we'll do studies with nasoesophageal pressure monitoring. So we can see the degree of respiratory effort. And we've clearly seen where as we decrease the amount of respiratory effort necessary to breathe because of administering positive pressure, we see the muscles relax. Okay. Now, if the pressure's too high, then you need to invoke the muscles to keep your mouth closed.
Okay.
So coming up with the right pressure is really, that can be more difficult than coming up with the diagnosis. The diagnosis can be easy in a real severe apnea patient, but coming up with the right pressure that's going to optimize physiology can be more difficult. But if you're at the right pressure, the muscles now have an opportunity to relax without compromising the airway, because it used to be that whenever the muscles relaxed, the airway becomes more compromised because the jaw starts to fall back. So the brain starts to realize that it can relax these muscles without airway compromise. But there's been all this conditioning of this phenomena going on for a long time. So what we see in a lot of these patients is any kind of an arousal can re-invoke the clenching process. And that arousal could be triggered by something like a periodic leg movement of sleep, which is another phenomenon altogether. Yeah. And so the person's having these periodic contractions of the anterior tibialis muscle. So when we'll see the leg twitch, and then the muscles of the airway are going to clench, even though it wasn't an obstructive respiratory event that triggered it. It could have been a leg movement. So I think there's a deconditioning that has to occur after a while, where the brain no longer tries to respond to any kind of disruptive event with this increased clenching.
Okay. So let me get this straight. So once you get treated for the sleep disorder, the actual treatment has to be effective enough for this deconditioning of the TMJ to really occur, because the airway has to overcome the restriction, which can require change in settings and stuff like that.
Let's go one step further, though. When you said treatment for sleep disorder, let's be more specific. When you have treatment for obstructive sleep apnea. Okay. So now, again, then if you have another sleep disorder, such as periodic leg movements of sleep, that's not being treated, that's going to continue causing arousal, then it's going to be harder to resolve the issue.
So I guess people, we call this PLMS, periodic limb movement disorder. Is that the same as restless legs, and what are the causes of this?
Okay, so they're two different conditions, but they overlap, right? So restless leg syndrome is something that you experience when you're awake. You'll have a person will lie there and they have a difficult time not moving because they develop an uncomfortable restless sensation. And then the movement creates stimulation and it drowns out that restless sensation. And go more into it, takes what's behind it. It's part of the monosynaptic reflex arc that's in our nervous system, and it's always functioning. And there's a little bit of static in that system. But if you have, let's say, a little bit of a neuropathy, or you have some compression on the nerve root, there's going to be a little bit of an imbalance. You're going to have more static. But when you're not moving, you're going to feel that static, because the static is going to go beyond the threshold of a filter, which is a dopamine filter that's in your central nervous system. And so your response is to move. And that movement creates stimulation, and then you no longer feel that uncomfortable sensation. But a minute later, it may come back. When a person's asleep, they can have periodic leg movements of sleep, which are these muscle contractions that occur in a periodic fashion. But if you can have periodic leg movements of sleep in your sleep without having restless leg syndrome, meaning when you're awake and not moving, lying in bed, you may not feel restless, right? But when you're asleep, you may have these periodic leg movements of sleep occurring. But almost everybody that has restless leg syndrome will have periodic leg movements of sleep when they're asleep. So, but again, some people will have the periodic leg movements without restless legs. So restless legs is something that you experience. Periodic leg movements of sleep is a phenomena we see on the sleep studies and occurs while you're asleep. The underlying mechanism is basically the same, that monosynaptic reflex arc. And when we treat these patients with a dopamine agonist medication, same kind of medications that were used to treat Parkinson's disease, it actually stops the periodic leg movements. And in the individuals with restless leg syndrome, it will resolve that restless sensation when they're not moving, because it's strengthening that dopamine filter. Now, that dopamine filter needs iron as a cofactor to function normally. And if you're a little bit iron deficient, then the receptor is not going to work properly. And so we see restless leg syndrome occurring in people that have iron deficiencies.
Yes, iron deficiency is a huge deal. Right. And it seems like it's not just iron deficiency. Like some people's iron may be in quote unquote in the normal range, but it's on the low side of normal, right? And they still supplement with it, and they have significant improvements in both restless legs and periodic movement.
So let's talk about how we define iron deficiency. Most of the definitions have come out through the assessment of anemia and hemoglobin synthesis, where you need iron. But that threshold is different when you're looking at the threshold of restless legs. So the ferritin is the best measure of metabolically available iron. Okay, protein floating around holding onto iron. So we use ferritin as our best measure, because you could have all your other iron parameters may be normal, but the ferritin may be low. And the lab is going to tell you that if it's over, let's say 10, 15, or 20, then it's normal. But when you look at restless legs, we need a ferritin greater than 50, all right? But the thing is, it's multifactorial, because some individuals, the receptor itself maybe the receptor doesn't need maybe as much iron, because they're not going to have restless legs and they're going to have ferritins of, let's say, 40. But other individuals, their receptors may need more iron, and they're going to have restless legs at, iron levels of ferritin levels of 40 or 25 or whatever. So it's a spectrum. The point being is that if you have restless leg syndrome, then iron should be one of the iron supplementation should be one of the considerations for treating. And your decision of whether or not you're going to use iron should be based on the ferritin. If it's below 50, you want to treat. In kids, we actually think maybe 75 should be the threshold.
For ferritin?
Yeah.
Because in the pediatric values at like Quest or LabCorp, it starts at like 8. It's the ferritin.
That's right? So off.
So even though it's not like red or looks abnormal, no, it really starts at 8. And I think 8 for females and 12 for males for the ferritin. You're saying in pediatrics, we're looking at like 70 for the ferritin. That's so interesting.
And that's because children have been shown to respond when they're given iron supplementation when their levels are below that, and they have restless legs. But many times, though, iron supplementation alone is not enough, and we may need to put an individual on a dopamine agonist medication. So,
and a lot of times, iron absorption depends on a whole lot of different things. You have the gut microbiome, you have intrinsic factor, you have a bunch of different things that are there. So, gut health is such an important thing. This is why when people actually eat better, their sleep gets better as well. There's so many pathways that are there. But I want to touch on something that's really common in the world right now. And that's specifically, and I have 3 daughters, which is why I mentioned this. That's specifically girls or women who have menstrual cycles and they have heavy menstrual cycles. Their ferritin is never at 70 or 50 or even 40 or 20. Their ferritin is like 12 or even single digits. That's a super common thing, right? So they're not just suffering like menstrual cycle and dysregularities. They have PMS and PMDD and really disrupted sleep, right? And so the right now, there's not necessarily a guideline for iron supplementation for the improvement of sleep, for the improvement of quality of life and stuff like that, right? And so can you kind of comment on that? Where do you think we should really be going with this?
Well, I think it comes back to taking the history. So when there is a young girl that falls into that category, heavy menstruation, and then if they're having problems with sleep, right, then start asking questions about restless leg syndrome. So, how do you feel when you lie in bed before you actually fall asleep while you're awake? Are you comfortable, or do you feel like you need to move around? And does the movement actually provide brief resolution of that uncomfortable feeling? And then once asleep, are there kicking movements? Are the sheets being kicked off the bed? When you wake up in the morning, are the sheets all ruffled up?
Oh,
And
that's my middle child.
so
Yeah.
clearly, you got to consider and periodic leg movements of sleep.
Yeah.
And clearly, you want to check the ferritin level and you want to put on iron supplementation. The problem that we have with restless leg syndrome, though, is that there is nothing that is currently, we don't have a medication that's been FDA approved for pediatrics. Now, I'll tell you that dopamine agonists have been used in kids. And there are reports that go back into the late 90s of showing improvement in ADHD in children that have restless leg syndrome and ADHD, and that responded to pramipexole and ropinirole. These are medications that were developed for treating Parkinson's disease. Now, the dose is much, much lower than what you need to treat the Parkinson's patients.
Gotcha. Well, let's relate that for a second, because my middle child also has some palate development issues as well. It's not just a low iron and stuff like that, right? So now let's change the subject a little bit. So we talked about iron, we talked about restless legs, how it contributes to not so great sleep. Let's get the topic going of the actual development of the palate, and how does that relate to all this? Going back to Johnny's story, right? And into the childhood again, like what should be done? What should have been done for Johnny as a child?
Well, you say should have, then it's implying that mistakes have been made. But let's say what could have been done, because you're sort of held to the standard of what the knowledge base is within your community.
So true, yeah. Mm-hmm.
And right now, the community is deficient in knowing things, but it's changing. I mean, the American Academy of Orthodontists. There's a lot of infighting going on right now within the orthodontic field of whether orthodontics should be retractive and straightening out the teeth, or if they should be expansive. And a lot of the orthodontists are realizing that what they do can impact airway, and that there should be an expansion done orthodontically in kids. You want to open up. You don't want to take out any adult teeth for sure. You need to make room. If there's crowding, that crowding means there's also an airway crowding. So it may take longer and be more extensive orthodontically to get things where they need to be, but you need to take that extra time to open up the airway in order to decrease the likelihood of developing sleep apnea later on in life.
Right.
And so what needs to be done is identifying this at an early age. Now, there are orthodontists and pediatric dentists that are doing early intervention. They'll do orthodontic interventions on 3 and 4-year-olds if there's already an airway compromise recognized at that age. And we keep on talking about the mandible and it being a small mandible.
Yeah.
Apparently, maxillary deficiency is highly underrecognized, and so it's you need to bring the maxilla out, and you don't want to bring the mandible back to meet the maxilla.
Well, let's put this in layman's term for a little bit. So when we talk about mandible and maxilla, can you just kind of define in layman's term exactly?
Right, so the maxilla is the upper teeth, and the mandible is the lower teeth, and the mandible is the moving part.
Yeah.
And so a lot of people have a small mandible, all right, and that's sort of what I talk about in Johnny. He's and that small mandible. That means your tongue, which starts right here in the inner aspect of the mandible, then it goes to the back of your throat, goes forward. So if your jaw is further back, your tongue starts further back. So your airway is already compromised. And that means the space in which you breathe through is already compromised. And when you start breathing through a smaller space and you try to get the same amount of air, you get a stronger vacuum. And that vacuum is what causes the tissue to vibrate, causing snoring. Snoring is a clear-cut sign of increased negative pressure in the back of the airway. So palatal expansion is one way to help open up the airway, and it brings the floor of the nasal passages down to open up nasal breathing, right? But you also have to bring things forward, and you got to bring the maxilla forward. So, and then when you have poor development, when you have a small airway to start with, then something like sucking your thumb is going to be a way of anchoring your mandible forward. So when you have a child that's continuing to suck their fingers, that actually helps their sleep, but it's also going to start compromising their dentition, and it's going to start changing the shape of their airway. But they're doing it because of compromise in the first place. So there's so many different aspects to this, and we can talk about the tonsils and how they contribute. Then we can even talk about whether the tonsillar hypertrophy is in and of itself a problem, or is it the result of having a narrow airway?
Yeah,
But
that's what I want to talk about.
now there's so many things. This is what I recommend.
Yeah.
We're having a conference. It's coming up at the end of April. It's 3
Yeah.
days long for dentists. It's 2 days for physicians.
Yeah.
The reason why it's different because the first day it's like a crash course for dentists and to learning how to get in there and examine the airway and learning more about some of the dental things that they could do. But it's a big conference that is really to help bring people up to speed because there's such a deficiency of this knowledge in our healthcare system. So the Sleep Education Consortium, which is a nonprofit organization that I started 19 years ago, has this annual course, and it's coming up the end of April. And I encourage people to go to it because we're going to cover more than, there's so many topics. We're going to talk about oral surgery, talking about early intervention orthodontics, myofunctional therapy, but you're also going to learn about restless leg syndrome from a world-renowned expert on restless legs, Dr. Bill Ondo. This is going to be one of the lectures, but you're going to learn about interrelationship between Ehlers-Danlos syndrome and mast cell disorder and something called the spiky leaky syndrome. Dr. Andrew Maxwell is coming here from California to talk about that. It's a cutting topic. There's a lot of patients, like POTS disease, autonomic dysfunction.
Yep.
He's a pediatric cardiologist, and he's gotten more involved in this. Did you go somewhere? The screen just changed on me. You there?
Sorry, I got interrupted video for a second. Yeah.
Oh, okay.
Yeah. Sorry, I'm back.
All right. But anyhow, so there's just, you're going to learn about orthodontic approaches. You're going to learn about some new oral appliances that are coming out that don't just pull on your mandible, but help stimulate mandibular advancement. So there's a lot to the conference. I encourage people to go, dentalsleepconference.com or medicalsleepconference. For the physicians, it's medicalsleepconference.com. And you're going to learn a lot about much more beyond, and you're going to be speaking at the conference as well.
I'll be speaking there, looking at markers of hypersomnia, which means sleepiness phase on imaging as well. And so let's, earlier you said there's things that could be done at a young age, could be done even in later stages, because there's a lot of adults who are going through the same thing. I'm actually undergoing expansion myself at this point. I'm 39, so quite beyond the pediatric years as well. And so, but I kind of do want to touch on the whole tonsillectomy thing and getting tonsils out because my middle one snored a lot and clenched and grinded quite a bit, and she had the typical sort of kissing tonsils, right? And so earlier we were just talking about whether the large tonsils, are they just large by themselves, or is it actually an effect of airway breathing disorders? What do you think?
So think about it. If you have a compromised airway and you open your mouth to try to overcome the compromise, now you have your air rushing through the back of your throat.
Oh, I see.
Right. And then there's also going to be more negative pressure in the back of your throat. The environment is going to be abnormal, and maybe that irritation and some of the other changes in terms of gas exchange may be a little bit altered because it's not normal, and the tonsillar tissue becomes enlarged and hypertrophied as a result of the abnormality. And then, so it clearly gets to the point where it's a snowball effect. So it's contributing to making things worse. The thing is, so let's talk about your middle child. Okay. If it was all due to tonsils,
yes,
and the tonsils came out, sure, there'd be improvement. But did everything resolve? Well, I just remember
not everything.
Saying there's still these other issues.
Yeah, exactly.
So
I want to know.
And now a lot of times, whenever you do any kind of instrumentation in the back of the throat, there can be increased muscle tone while everything's irritated. Right? So post-operatively, there's going to be improvement, but that improvement won't last more than maybe 3 to 6 months. Once the healing is complete, once healing is complete, everything starts to relax again. So if you're going to do another study to assess the efficacy of the surgical intervention, you need to wait at least 3 months, if not longer, because you may get a epiphenomena, of improvement. You may get improvement that's transient. It's not truly improvement. It's because the muscle tone is increased temporarily. So remember those pillar procedures that was done on the soft palate? You put in those pillars supposed to treat sleep apnea. Well, when they did the assessment, they did it right after they did the procedure, and there was a false improvement. 3
Oh,
months later, those patients were back to having their problem.
it's like after the body compensates, you're kind of ending up with a very similar problem to begin with. And you're right with my middle daughter. It's about 3 months that she actually had improvements, and then now it's kind of going backwards, right? And so, but it's not. What I noticed is that for a lot of patients, a lot of people, it's not really just about the oral airway. We're seeing some like sinus airways close up too with a lot of mouth breathing, right? And they have chronic sinus disease. Can you kind of comment on that one?
Well, it's all a fixed structure. It's all interrelated. So
Yeah, one system.
let's say,
Yeah.
let's say you have a high arch palate, right?
Mhm.
What we call a cathedral palate, up at the top of your mouth. It's really high. Well,
Yeah.
what are you impinging into? Your nasal
Oh
passage.
yeah, yeah. Your nasal sinuses,
So
right?
if this is a fixed, geometric anatomy, so if the higher your palate, the smaller your nasal passages. But you could have other kind of anomalies in your nasal passages. You need to be able to breathe through your nose.
Mm.
The thing, so an ENT surgeon is crucial to the overall success in many patients. But the misperception is that the nasal intervention alone will resolve the problem. And
Mhm.
usually it doesn't. Having a nasal intervention will probably resolve 10% of the patients or less of patients that have obstructed breathing during sleep. But you got to get you have to open up the nasal passages so that you can breathe through your nose and you don't have to resort to oral breathing. So a dental appliance that you may be using for treating sleep apnea, or even if you're just using nasal sleep ep itself, you've
Mm.
got to take care of the nasal obstruction. But if you want to talk about fascinating things, I'll just throw out one more thing
Yeah. Yeah.
that's so how did we get this way? How
Yeah.
why
How do we
are
get this way?
how are humans like this messed up? You got to think of this part of your anatomy. You use it to talk, eat, and breathe, right? And so it's got to have multiple functions. Um, but the mobility that we have for talking and eating makes it unstable in terms of breathing. Well, if you look anthropologically, now Kevin Boyd, who's a pediatric dentist, world renowned, and he does early intervention orthodontics, but he's been studying this with a few other colleagues where they've taken skulls of humans that are hundreds of years old and they don't see the kind of issues we see now. They have bigger mouths,
Hmm.
all right, bigger airways. Now, so why is that? Well, what's thought has happened is that with the Industrial Revolution, and the creation of bottle feeding and processed foods at an early age we're not individuals and children are not challenging their mouths, so they're not having
Yeah.
to work as hard to eat rather, and so there's less growth that's occurring in this part of the anatomy, and then through epigenetics we're passing that on to our next generation.
Yeah.
And so over a series of generations now we've developed smaller mouths, smaller
Mm.
airways. Well, that's making a problem when it comes to breathing during sleep. So the occurrence of sleep apnea is probably higher now than it used to be 500 years ago.
Yeah. Well, I mean, even 200 years ago, I think. So, because a lot has changed, and especially if we think about it right now, right? What is the most famous kid food for toddlers is Gerber's, right? Everything's kind of mush, and there's no stimulation like eating an apple and stuff like that. And when I was talking to Dr. Felix Yao, he talks about, hey, as at 4 to 6 months of age, you should be challenging the jaw with like harder things. But there's sort of this concept of like choking hazard, and I think the popularity of this concept called choking hazard has also made parents like myself and my wife very fearful of introducing these solid things even at 1 year old. Does that make sense? Yeah. So if we have developed these small airways over time, now what percent of the population are we talking about have these issues?
Well, it's hard to say. When you look at statistics, it's going to say maybe 4 to 6%. Some statistics will say even lower, like 2% of children will have obstructive sleep apnea. That's the part of the issue is how do you define obstructive sleep apnea? And as time has gone on, we've recognized that more subtle degrees of obstruction
Mm.
really need to be tabulated and calculated into the diagnosis of sleep apnea. So there are we just don't have great statistics, but I would say that at least 10, 12, 15, maybe 20% of the pediatric population have deficient airways, right? But then the question is, and it might be higher. I know there's some people that are going to say, Jerry, why are you being so conservative? You know, it's much higher than that. I mean, some of my colleagues will say, 25 to 50% of people have, but I think that's a little bit beyond what I'm comfortable saying. But either way, whatever the number is, the reality is it's common, and it's a healthcare professional. You have to be sensitive to these issues. And that's where the deficiency has been. We haven't been. We tell parents, they're going to grow out of it. There's not an issue. But the more we start recognizing these more subtle degrees of obstruction causing sleep fragmentation that could lead to other kinds of issues, then we're going to start making an intervention sooner. And there's a lot going on right now in terms of coming up with screening methods. And I'm actually a consultant for the American Dental Association, working on a screening protocol that hopefully will get implemented. We hope to get funding to validate a process for screening kids, as starting off as simple as a 5-question questionnaire that hopefully ultimately can be administered in the schools. And so, if we can start screening at an early age, and we have a pathway with which children can be properly evaluated, and we have people that are talented to do interventions to open up these airways, then we're going to reduce the overall airway burden or sleep apnea burden on the next generation. Because we know that heart disease and cardiovascular disease, high blood pressure, those things, even diabetes, are made worse by obstructive breathing during sleep. When you are having fragmentation of your sleep throughout the night, your adrenaline is getting kicked out throughout the night, and all this cortisol is getting kicked out during the night. All that causes insulin resistance, and that decreases glucose. It decreases glucose resorption, and so your sugars get higher. So you're developing insulin resistance. So I mean, there's just so many other aspects of how obstructive breathing can be detrimental to health. So if we can change the anatomy at an early age, it will make the next generation a healthier adult. The adults in the next generation will be a lot healthier.
Multiple generations. It can eliminate generational epigenetic expression of small airway syndrome. Now, in 2021, the CDC says that obstructive sleep apnea is an independent risk factor for COVID-19 mortality, which means that's independent of obesity, is independent of age. If you have obstructive sleep apnea, it's an independent risk factor for COVID-19 deaths. So let's talk about COVID. Let's talk about sort of long haulers and how is that related to everything that we're talking about?
Well, it's okay. There's two, you talked about in the acute setting of COVID. We know that the inflammation is a big part of that, and we know that positive pressure therapy helped decrease the atelectasis and can improve the removal of a lot of the mucus and just the inflammatory fluids that were accumulating in the lungs. But people that
positive pressure therapy, meaning like CPAP or BiPAP.
Yeah, CPAP and BiPAP. That positive pressure helps prevent the collapsing of the tissue of the alveoli, something called atelectasis that can develop. So it wasn't so much the virus itself; it was the inflammation that was causing the big problem. So and if you have sleep apnea, your risk of having major pulmonary compromise is much higher. And if you look, a lot of the people that died were obese, and I would put money on the fact that a lot of them had sleep apnea that just was not diagnosed.
Right.
And so,
or diagnosed and not treated.
Well, or just not diagnosed, because most sleep apnea patients are not diagnosed because most physicians aren't thinking about it. They're waiting for the spouse to describe a classic case of sleep apnea before they'll say, okay, they're not screening. They're not asking the probing questions and getting the testing done. But anyhow, so what do we do? So what were we doing? We finally realized that giving steroids was a way to help these patients, right? So everyone that's getting COVID get put on prednisone, right? And you get Paxlovid and whatever, and take steroids. What do steroids do? Well, they can actually cause insomnia. Right. And there's actually some studies that were done looking at long COVID and what were some of the problems. And sleep issues affected at least 25% of patients that have long COVID had sleep issues. And out of that, most of them had insomnia.
Mm-hmm.
And then when you look at the kinds of things that contribute to insomnia, well, one, taking steroids it's a side effect. And that could start a cascade of developing poor sleep habits. And then you get more anxious about going to sleep because you're having insomnia the night before. And that anxiety increases the likelihood of having insomnia again that night. So you develop like a snowballing effect to where you get conditioned to where you're anxious about going to sleep, and that anxiety makes it harder to go to sleep. So there's and plus you're staying inside and you're not getting the bright light exposure, which you need to regulate your melatonin fluctuation. You need bright light during the day and darkness at night. So people were having poor sleep hygiene, and they're just developing a lot of poor patterns. So that's part of what's going on with these patients with long COVID. But then the question is, could long COVID itself, if you took out the insomnia issue, if you took out medication aspects, could it be affecting the brain? Mm-hmm. Well, it may be, and there are some things to suggest it. I mean, we're now finding that maybe it's self-limited, and maybe after about 18 months or so, some of this brain fog phenomena may go away. But what we have to tease out is how much of the brain fog is coexisting with other complaints, such as sleep complaints, such as insomnia. And a lot of these individuals actually that are complaining of brain fog do have poor sleep. So the statistics is just now starting to come out to try to get that figured out. But there is the issue of having a cerebral inflammatory process going on, maybe. And some patients, clearly, there's some patients with long COVID that develop hypersomnolence, increased sleepiness. So narcolepsy can actually has occurred on some of these patients.
Yes.
And we don't have time to really go into narcolepsy, but it's associated with, it can be from an autoimmune phenomenon. So, long COVID is a newly recognized phenomenon. It takes years to really sort all this stuff out, but sleep is highly interwoven into the symptom complex of a lot of these patients.
Yeah, I agree with you. And one thing, or multiple things that really support it, is that we have sort of this 3 to 6 month hair loss, which we call the COVID-induced telogen effluvium, and that occurs. But in reality, your hair follicles grow during deep sleep, and a lot of times when you get COVID, your deep sleep gets knocked out for a period of time, and that perpetuates the hair loss as well. And the other thing is, whenever there's an exposure of S1 spike protein to the mucous membranes, we know that the mucosal thickening in the maxillary sinus dramatically thickens, right? And there's actually an article published in the ENT journal, I can't remember, showing improvements with just intranasal steroids like fluticasone, which is basically Flonase over the counter, that can help as well. So, and that can actually improve sleep as well, speaking of the steroid phenomenon, right? So we see that as well, published in late 2020. And then the other thing about the long haulers phenomenon is I think you're right. I think there's an inflammatory component to it that creates this cascade of inflammation that we're seeing. And another doctor, Dr. Dale Bredesen, I interviewed, who wrote the book of End of Alzheimer's. He's like, this is like people having like acute Alzheimer's almost, where all this huge cascade of inflammation are actually affecting the lymphatic system, the detox system of the brain as well. And so it really is multifaceted. And I really have to kind of give a big shout out to chiropractors and physical therapists out there, because, without them, it's really hard to, improve detoxification, the lymphatic system, shunting, and the lymphatic drainage of the entire upper airway. If the rest of the spine, if the rest of your hips aren't misaligned, if you have a lot of chronic knee pain and stuff like that as well. So, and not get into that, it's far too complex. But for the purpose of this talk today, it's really about the skull-brain connection. There's a massive skull-brain connection, massive airway-brain connection. It's not really just about the skull. You have some soft tissues in the skull as well. That's really related to everything. And we can really no longer ignore the fact that, here's the thing. You're a triple board certified neurologist talking about orthodontics, as a huge, solution for brain disorders and even mental health disorders, right?
Right.
And so this is as integral as we can get. So for those doctors and dentists, for doctors out there, go to medicalsleepconference.com. If you're a dentist, go to dentalsleepconference.com. We have something, or Dr. Simmons has something really special planned for you guys. I'm talking on there as well. And if you come to the conference, I'll actually give you a signed copy of my book as well as a gift. And it's really just get the word out there that we really need to work together as multifaceted medical professionals in an integrated system to come up with solutions for brain and mental health. And that is my big message for today. And the other thing is, for those people who are not medical professionals, we'll be doing a whole lot more of these a little bit later on, relating everything to brain health and skull health and airway health and everything like that. So stay tuned and subscribe. If you're listening on YouTube, make sure you do subscribe. Listening on Facebook, make sure you have some likes and follows as well. If you're listening on LinkedIn, you know more is coming because I'll schedule more as well. But Dr. Simmons, I want to thank you for being here today.
Thank you.
We're about 55 minutes in, which is a great time. I wanted to hit before an hour stops.
Yeah, actually, I have a patient scheduled in 5 minutes.
Okay, so we'll definitely stop for you. But thanks for being on. And this is such an important video. It's probably one of the most important videos I think I've done. And we're definitely going to get out to the email list. But once again, for those doctors listening to this, come join us at the medicalsleepconference.com. For those dentists, go to dentalsleepconference.com.
I guess I should point out also that right now is the early bird registration, so there's a significant discount. And if you register during early bird, you'll have access to stream all of the lectures from last year's conference.
Oh, great. Awesome. Yeah.
So that's available. So you not only get the registration to attend this year, and it's like 25 hours of CME credits, and same for dentists. And then you also get all the content. You could watch the videos from last year's conference.
Amazing. Well, thanks for being on, and you get to your next patient, and we'll chat later.
Sounds
Thanks,
good.
everyone.
Bye.